think we're at a point in the research where we're all just trying to grasp what is cost conversations. And perhaps it's going to be this overarching area, and within that we'll begin to define the terms and the areas that we need to explore further. You know, we already have the term of out-of-pocket cost, and that's a little niche in itself. We have those, you know, little life costs or transportation costs, and maybe we'll continue to further explore those. But I also think is where we're going to also start to move is what are the ways in which we can begin to measure and explore as we kind of narrow down and continue to come together in these kinds of panels and conversations to further hone in and define and articulate what a cost conversation is.
Oftentimes what we experience in Mississippi is that it's a trade-off. Oftentimes patients, we have a huge problem with non-adherence. We have a huge problem with patients not keeping their appointments. We have a huge problem with people having to decide if they're going to pay their utility bills or pay for whatever other expenses they have besides medical expenses. So we have all of these issues that are going on. We often have people that cannot, even though they have employment, they cannot choose to afford the insurance coverage because if they do, they pay home. The amount of money they bring home is not enough to pay for their daily expenses like utility, you know, transportation, childcare, all of the things that others talked about earlier today. And what we shared earlier when I spoke with you, I have a patient in Mississippi that was diagnosed with a cardiomyopathy, postpartum cardiomyopathy. Is a mother of three, single parent, works at McDonald's, and chose not to sign up for health care because she could not afford it, and she needed more money to bring home to be able to take care of her family. So those are the type of trade-offs. But if you hear that one story, this happens every day. This is what I'm dealing with every day in clinic.
It's not like we have all this information and we're not sharing it. This information is fragmented. It's in different places. We don't really know what the validity of some of these data are. And depending on who you are, the costs are probably very different. And there is no mechanism for us to understand not only the costs of us providing care within our health system, which sounds silly, but we don't have a good way of measuring it. Few health systems really know the cost of providing care, if you can believe that. And then we're talking about the costs from the patient perspective, which is obviously not only what's happening in the doctor's office or perhaps in the waiting room or elsewhere, but then also in the home and the lives and how all of this affects people. This is an area that needs better visibility and more ways of understanding what those costs are. The way we see the cost of care, and this is a very indirect measure, are people coming late to appointments, people that are missing appointments. These are all the conversations we need to have, but have no idea of how to even start that conversation. So we're seeing it in readmissions, we're seeing it in poor disease control, we're seeing it in missed appointments. Those are probably all costs of care that we have not been thinking about it as a cost of care. As a practicing physician, I think that when cost of care issues are interfering with patients' lives, it not only is frustrating, I think, to the patient, of course, and family members, but also it adds to the treating burden, because at the point of care, you're trying to imagine, how do I do what's best when the elephant in the room is cost, and I don't have a good idea of what the cost is.
When I remember going through my curriculum, we did not get trained to talk about cost of care. So I think even going back to the basics, going back into the curriculum and start, preparing providers to talk about cost of care, because oftentimes when clinicians do not talk about cost of care, it's not because we don't believe that it's real, because we understand it, because we ourselves have to go through different care with ourselves and with our families. But you try to separate the two because you want to focus on care. And oftentimes you have to be there's a very thin line there. So you have to be very careful when you're talking to a client about cost of care, because sometimes the patient may feel like, okay, if you're talking about how much the test costs, are you going to still provide me the same type of care if I don't have insurance coverage? So you have to, there's a very thin line there, but at the same time, how do you avoid it?
One of the first things or themes that emerged from our research was, engaging with individuals. One was, we started with, how would you like to talk to your provider about cost, or how would you like to go about that? And then it came through that I just don't, and we even asked individuals on a scale from 1 to 5, how comfortable are you engaging with your provider about cost? And we observed healthcare is perceived as very hierarchical. So if a doctor doesn't initiate a conversation about something, the patient will not engage that. The patient's like, I only got 15 minutes. And both patients and providers are saying, we only got 15 minutes. I'm not going to interrupt the doctor. I'm there for medical care. I'm not going to interrupt. I just want to get as much as I can in that 15 minutes. I'm there for medical care. My favorite quote is, my doctor has an MD, not an MBA. The idea of not wanting to question your doctor. We even brought up the notion of cost screening, or screening for cost sensitivity. Whatever we call it, is just kind of getting a sense of what the patient is able to afford during that day. And even then, I had some participants say, so how would you feel about this? They go, I'd lie on that, because I wouldn't want the doctor to give me less than care. I'm going to say the onus really falls on the providers to initiate that conversation in some way. And back to the opening question is that, maybe that conversation doesn't actually have to include the word cost, because there's so much in that word, but maybe there is another word, and I don't quite have that yet.
Creating a plan together and co-creating a plan, and that it's a pact and an agreement between the healthcare provider and the patient and their family.
Perhaps we need to do some research to understand between those two options which horse wins the race at the end. It may not just be the drug costs. It could be the side effects. It could be missing work. It could be any number of things that accumulate over time. And in fact, the lower cost approach, lower drug cost approach may not be higher value at the end, or the other way around.
As a patient, I would want my doctor to talk to me about cost. Now, I haven't always been there, but I would rather be shamed in my doctor's office where it's just he and I, or she and I, rather than get to the pharmacy where they've written me a prescription and they tell me it's $100 and I can't afford it. And then I got to tell the pharmacy, I can't get that, I don't have that kind of money. And so then he tells me, well, you have to call your provider. And so I've learned over the years that there's no shame in my game, because it's going to work for me. Mm-hmm. So whatever is better for me, I don't have a problem with doing it. So now, when I'm in the doctor's office, I ask, when they finish talking, I ask, well, what is the cost? Don't write me no expensive prescription, because I can't afford it. I tell them, and so I understand if someone is ashamed to talk to about their finances, because I was once there. Okay. But once you go to the pharmacy enough, and they tell you how much that prescription costs, and you stand there and say, I don't have that money, you'll learn to, okay, there's no shame in my game.
There were 2 surveys that were presented. The Public Agenda survey that said that 70% of Americans want to have cost of care conversations with their providers, and only 28% report doing so. And that was something that was published in by Public Affairs, but also cited in a new blog in Health Affairs. And then our PAF data say that 74% of cancer patients and 78% of HIV patients agreed, or strongly agreed, that knowing about their cost of care influences the treatment decisions, is important in making their treatment decisions.
I think we need to start with what I call normalizing the cost conversation. I think cost conversations aren't with just individuals who you see are on public insurance. I really believe that it's also the individuals who are high deductible plans. Like Tom was mentioning, oh yeah, everybody thinks I'm retired early and I'm living on the high, but really you're struggling with medical costs. And so as we're seeing high deductible plans become more and more prevalent, the individuals who you assume might not be struggling with costs might very well be paying the most out-of-pocket costs. At the same time, I think when you normalize it along across all individuals, the individuals who may often feel singled out or stigmatized as having that cost conversation, you can actually sincerely say as a provider, this is a conversation I have with everybody.
We need to acknowledge it, and we need better information about what are the total costs of care for different types of individuals. We need to recognize those costs of care are going to vary tremendously for the same condition depending on the circumstances of that individual. So we need to think more broadly than the average cost. The average, I think very few people are average. The other point might be that we may also, with whatever information we currently have, develop tools to facilitate that conversation.
Most of the value discussions have come from a lot of them come from an economic model. They don't come from a humanistic model, and many of them are focused on what is going to be paid for and not paid for by the system, not what the value is and the cost and cost considerations are for patients, families, and communities. So I think we have to flip this conversation and really flip this value conversation and the cost conversation around value.